Hello friends, welcome to my channel. So as discussed in the previous video that I'll be putting some academic opthal content here. So today I have chosen the topic nystagmus. I feel this topic is a bit difficult to understand the classification or the clinical features and understanding the etiology of different type of nystagmus. So we'll start with the definition of nystagmus. I have taken the sources from two books. One is Kansky and other is A.K. Khurana. The same we study in our UG as third year students. So nystagmus is involuntary contraction. So nystagmus is involuntary oscillation of eyes. It is regular and rhythmic involuntary oscillation that can be physiological or pathological. So basically physiological normal भी हो सकता है मतलब uh, for example following the rotation of an optokinetic drum which is used to elicit nystagmus and that is a normal kind of nystagmus and it can be pathological also. So what is actually nystagmus? Nystagmus consists of a cycle of movement initiated by an involuntary defoveating drift of eye away from the target, followed by a refixating saccadic movement. So basically, uh, there are two components of nystagmus. One is the slow defoveating drift, which is involuntary, and that goes away from the target. And the other movement in the opposite direction is refixating movement, and that is the fast movement or the saccadic movement. Uh, in order to classify nystagmus, we talk about its features. There are features like plane. So the plane may be horizontal, vertical, or torsional. That is in all the axes X, Y, or Z. And then we talk about the amplitude, uh, which will tell us whether the nystagmus is fine or coarse. And then we'll talk about the frequency, which can be high, moderate, or low. The fourth property of a nystagmus is conjugacy, that is, it may be symmetrical or conjugate, or it may be disconjugate, that is, in different directions and different frequency in the two eyes, so that the two eyes are not matching. And it may be dissociative, that is, it can be unidirectional but asymmetric. So the fifth property is manifest or latent. That is, manifest means the nystagmus is present in all the time and latent means that it is only present when one eye is covered. So when we cover one eye, the other eye will show nystagmus, and this is what we call latent nystagmus. Then we have a sixth property, and this is a very important property for classification, that is the waveform. So waveform may be like it can be jerk, or it can be pendular, or it can be mixed. Jerk nystagmus, as I told you, it has two components. It has a slow defoveating. Defoveating means that the fovea is moving away from the target. Drift, and there's a fast corrective refoveating. Corrective because it is moving towards the target now. So it is fast, that is it is saccadic, and it is refoveating, corrective movement. And this fast component or this refoveating saccadic movement is the one which tells us what is the direction of that nystagmus. So if we say that there is right nystagmus, that means that the fast component of that nystagmus or the saccadic movement is in the right direction. It can be right, left, up, down, or rotatory. Now, then there's a pendular nystagmus. So, what if there's no slow or fast, but the movement is of equal velocity in both the directions? Then we will say that it is a pendular nystagmus. So, the foveating and the defoveating movements both are slow and both are equal in both directions. Then there's mix, that is, it consists of pendular nystagmus and jerk nystagmus, pendular in primary and jerk in lateral gaze. So this is an example of that. Now, this is something interesting, that how to document a nystagmus. If you see a nystagmus, how will you put that in a diagrammatic format to show that what kind of nystagmus is seen? Here you can see normal directions like right, left, up and down, and pendular. So that is easy to understand that that will tell the direction of nystagmus. Like right is going in the right direction, left is going in the left direction. Now, mind you, this is in patient's perspective. Uh, that is like left in the patient's eye, so your right will be patient's left. So this is left. Then the length of the arrow will show us the amplitude, like low amplitude will have a shorter arrow and a high amplitude will have a longer arrow. And the number of arrows will tell us the frequency. Like this is low frequency, one arrow, moderate frequency, two arrows, and high frequency has three arrows. And this is something new. This is torsional nystagmus, which is showing a different category of arrow. After documentation, now we'll come to physiological nystagmus. Physiological nystagmus can be mainly of three categories: the endpoint nystagmus, the optokinetic nystagmus, and the vestibular physiological nystagmus. Because vestibular has two types, the physiological and the pathological. So the physiological vestibular nystagmus will be a part of physiological nystagmus. Now coming to the first one, the endpoint nystagmus. This happens when a person is seeing in extremes of gaze. Like, suppose a person is seeing to extreme left or to the extreme right. Then, at the end point, the person may experience nystagmus, and this is totally physiological. This is a fine jerk nystagmus of moderate frequency, and the direction of gaze. And the direction of nystagmus is in the fast phase. So if a person is seeing in left direction, then the fast phase will be also in left direction, and that is we will say that that is the direction of nystagmus. So left gaze, left nystagmus, and left fast phase. This is how we'll put the endpoint nystagmus. The second one is optokinetic nystagmus. Optokinetic nystagmus is induced by moving repetitive targets. For example, a OK and drum. Uh, it is similar to a person sitting in a moving train and looking outside. So the target in front of you is constantly changing, right? So that is how a OK and drum is. The visual target is constantly changing. So here what happens is that there's a slow phase and there's a fast phase. The slow phase is the pursuit movement in which the eyes follows the target. And then there's a fast phase that is a saccadic movement in the opposite direction because the next target comes and now the eyes move in the opposite direction to see the next target. Hmm. Here the slow phase controlled by parieto-occipital temporal region of the brain, and this is ipsilateral to the target. Also, the fast phase is controlled by frontal lobe, which is also ipsilateral to the previous target. Now, what is the use of using a OK and drum, or why do we want to induce this kind of a nystagmus? So it has three types of uses. The first one is detecting functional or non-physiological blindness. When we want to see whether the person is blind or not, we can induce a nystagmus, which will show us that yes, the person is not blind or blind. The other is to assess the visual acuity in very young, and to assess isolated homonymous hemianopia. We can use an OK and drum. Finally, coming to vestibular nystagmus. Vestibular nystagmus, as I said, it has a physiological type and a pathological type. So, it is induced by different temperature, what we call as caloric stimulation. Like if we put cold water in right ear, it will give a left jerk nystagmus, and if we put cold water in left ear, then it will give right jerk nystagmus. This can be remembered by a very simple mnemonic, that is cows. Cold induces opposite, that is right to left and left to right, and warm water induces same WS, right to right and left to left. Now, what if we put cold water in both the eyes? Then the fast movement will be in the up direction and slow movement will be in the down direction. And I told you that the direction of nystagmus is determined by the fast component. So the direction of nystagmus will be in the up direction. Now, how to remember this? And it is important for it is opposite for warm water, that the fast phase is downwards with warm water. Now, to remember this, there's a mnemonic given here that cold slows things down. So basically, when you put cold water, the slow component will be in the downward direction. If you remember that cold slows things down, you can remember that cold, the fast component will be up, that is nystagmus direction will be up, and in the case of warm water, if we put warm water, the nystagmus direction will be down because the fast component will be down. And this test may be used to see if there's a peripheral vestibular disease, because if it gives an abnormal test, then we can say that the person has a peripheral vestibular disease. Coming to the pathological category of vestibular nystagmus, the pathological vestibular nystagmus occurs due to a vestibular disease, like a disease, we can say labyrinthitis, Meniere's disease, any infection of middle or inner ear, and this type of nystagmus worsens with gaze towards the fast phase. Now, if we say that the nystagmus is in the right direction, that is, the fast phase is in the right direction, and the person sees in the right direction, then that nystagmus will worsen, and also it improves with fixation. Now, this nystagmus is of fine amplitude. Now, I want to discuss with you the classification of eye movements, abnormalities, and strabismus. That is the CMAS classification of nystagmus, and it will make a bit easier for you to understand the types of nystagmus now. So, I discussed the physiological nystagmus with you, that included the endpoint, optokinetic nystagmus, physiological vestibular nystagmus, and any kind of voluntary nystagmus if there. Then all of these is physiological nystagmus. And the pathological nystagmus we can broadly divide into the early onset nystagmus and the acquired nystagmus. So basically, what we considered previously as congenital nystagmus is now called as early onset nystagmus, because it manifests in infancy, in the first year of life. So we don't tell that it is a truly congenital nystagmus. Rather, we say it's an early onset nystagmus, or the nystagmus can be acquired. So the early onset nystagmus can be broadly categorized into three types. That is the infantile nystagmus syndrome, the fusion maldevelopment nystagmus syndrome (FMNS), and the spasmus nutans syndrome. And then there are acquired nystagmus, the classification of which I'll be discussing a bit later. Coming to early onset nystagmus, or infantile congenital nystagmus, though it is not truly congenital. Coming to fusion maldevelopment nystagmus syndrome (FMNS) is a latent or manifest nystagmus. The one which I told you will manifest only in monoocular conditions, that is, when one eye is covered or you cannot use it. For example, anisometropic amblyopia or strabismic amblyopia. Amblyopia means that the visual pathway is not developed, which occurs in childhood. So that can occur due to power difference in both the eyes, or it can occur due to an existing squint. So if amblyopia develops, that is, the child cannot see with one eye. So we will say that this is a monoocular condition. So this type of nystagmus manifests in monoocular condition. So it occurs in first year, and the kind of strabismus which can be associated is congenital esotropia or dissociated vertical deviation. Dissociated vertical deviation means when a person is not focusing, uh, then one eye goes upward and one eye goes downward. This is called as DVD, or dissociated vertical deviation. The deviation is dissociated. One is up and one is going down. Now, the important point here is that the intensity of this nystagmus decreases with age. And for the direction, now this is a kind of jerk nystagmus, and fast phases towards the uncovered eye. Occasionally, this nystagmus can also be low amplitude pendular nystagmus, but mostly it is jerk nystagmus with fast phase towards the uncovered eye. That is the eye which can see. The other eye which cannot see, the nystagmus is not in that direction. Now, coming to infantile nystagmus syndrome. Now, infantile nystagmus syndrome can be idiopathic or it can be due to sensory deficit. And this is a very common type of nystagmus. What kind of sensory deficit can cause nystagmus is like someone having congenital cataract or bilateral macular hypoplasia or congenital albinism, Leber's congenital amaurosis, any optic nerve hypoplasia, achromatopsia, or any congenital stationary night blindness, which we say CESNB, and any bilateral congenital toxoplasmosis. So all these conditions will cause a sensory deficit. And if a child has bilateral diminution of vision in less than 2 years of age, then the child may develop nystagmus. Now, the characteristic of this nystagmus is that it has accelerating fading. This is the diagnostic point for this nystagmus, that it has accelerating slow fading. And these children develop a head posture which is evident by 4 years of age. Associated findings is that this nystagmus shows a progression. It goes from pendular type to the jerk type. The family history is present, and it may have neutral or null zones. Also, this nystagmus may decrease with conversions, with the increasing fusion, or with any kind of extraocular muscle surgery, like we can take for strabismus, or with contact lenses and with sedation. Now, coming to spasmus nutans, that is the third type of congenital or early onset nystagmus. So, it is a small amplitude, high frequency, like you can elicit from this term here, spasm. So, it has small amplitude and high frequency horizontal nystagmus, which is associated with head nodding, and a normal head posture. And both of these things improve in childhood as the child grows from infancy to childhood. Head nodding and head posture, normal head posture improves. Causes are idiopathic, that is, it resolves by 3 years, any glioma of anterior visual pathway, porencephalic cyst, or empty cellular syndrome. These conditions can cause a spasm-like nystagmus, which we call as spasmus mutans. This is a rare condition which is present between 3 to 18 months of age, unilateral or bilateral, and the amplitude increases on abduction. Now we'll come to the last category, that is acquired nystagmus. So acquired nystagmus can have different types of classification. One type is according to the causes, like it can be due to disorders of visual fixation, or it can be vestibular, or it can be due to disorders of case holding. Another classification may be according to a clinician, how the patient presents, like the nystagmus can be vertical nystagmus, or it can be horizontal nystagmus, or it can be something complex that cannot be categorized as vertical or horizontal. So we'll approach both these things because we need to understand the etiology, and also we need to diagnose according to a clinician's perspective. So, firstly, coming to due to disorders of visual fixation, any vision loss nystagmus can occur due to disease of retina or the optic nerve, optic chiasma, or any structure up to visual cortex. It can result in vision loss nystagmus. Vestibular nystagmus can be characterized into peripheral vestibular nystagmus, as I told you, which had labyrinthitis, Meniere's disease, and the second can be central vestibular nystagmus, which can have four subcategories. That is the upbeat, the downbeat, the seesaw nystagmus, or the periodic alternating nystagmus. I'll explain all of this in detail in the upcoming part. The third category can be nystagmus due to disorder of gaze holding, which includes gaze-evoked nystagmus, ataxic nystagmus, convergence retraction nystagmus, Bruns nystagmus, and centripetal and rebound nystagmus. I'll discuss all of this in detail. Now, after understanding the etiology, we come to nystagmus, which can be broadly divided according to clinician perspective. Firstly, we have a vertical nystagmus, uh, which can be upbeat nystagmus or downbeat nystagmus. Downbeat nystagmus is a nystagmus which has the fast beating component downwards, because the uh, fast component describes the direction of nystagmus. It can occur due to ulnar cherry malformation, syringobulbia, drugs like lithium or phenytoin. Now, this is something which can be common in psychiatric patients. So we have to keep this in mind that lithium or phenytoin can elicit a downbeat nystagmus. If you see a patient with the downbeat nystagmus, ask about the drug history. Wernicke's encephalopathy, demyelination, and hydrocephalus. And this type of nystagmus is often most clear in the lateral case. Coming to upbeat nystagmus. Upbeat nystagmus suggests a pathology of the posterior cranial fossa. It can include posterior fossa lesions, drugs, and Wernicke's encephalopathy. And obviously, the fast beating component is upwards in direction in upbeat nystagmus. Now, coming to horizontal nystagmus. Horizontal nystagmus mainly consists of four types. It has periodic alternating nystagmus, latent nystagmus, and it has Bruns nystagmus, and it has ataxic nystagmus. I'll be discussing all of this in detail. The first one is periodic alternating nystagmus. Uh, this was a very interesting type of nystagmus because it has three phases. The first phase is the active phase, that is the nystagmus beats in one direction, and the amplitude, the frequency, first it increases, then it decreases. Then there comes a null period, that is a 10 to 20 second of a period where there's a low intensity of nystagmus, often pendular movements, not in the right direction, not in the left direction, but they show equal pendular movement. And then there comes a third phase, that is the reversal phase. Now, the direction of nystagmus is opposite here. First, it was maybe starting here, then it showed pendular movements, and now then the direction of nystagmus is here. And so that's the total cycle, which occurs in 1 to 3 minutes. This is called periodic alternating nystagmus, and it is a conjugate horizontal jerk nystagmus. Then the second type is no, coming to the etiology, can be due to congenital causes, or it can be due to cerebellar disease, or it can be due to ataxia telangiectasia, or it can be due to phenytoin. Coming to the next one, that is Bruns nystagmus. It is second type of horizontal nystagmus, and it combines two distinct type of horizontal nystagmus observed in the same patient. One is the coarse component, which is cerebral horizontal jerk nystagmus, and the other is the fine component, which is a high frequency vestibular nystagmus. So, a same patient has a jerk nystagmus and a vestibular nystagmus. Jerk one is obviously the coarse component, and the vestibular nystagmus is the fine component. It can be a suggestive of cerebellopontine angle tumors, CP angle tumors, CPA tumors, such as vestibular schwannoma. Third category is the ataxic nystagmus. Ataxic nystagmus is a pathognomic sign for internuclear ophthalmoplegia. It is a horizontal jerk nystagmus that occurs exclusively in the abducting eye of the patient. And obviously, it is you should see for the other signs of INO because the diagnosis is contextual. Then coming to latent nystagmus. Latent nystagmus is something, as I discussed earlier, that it will manifest when one eye is covered. The other eye will show nystagmus, a horizontal nystagmus. The fast phase of the nystagmus is in the direction of uncovered fixating eye. In case of manifest latent nystagmus, a pre-existing nystagmus significantly increases in amplitude when one eye is covered. It can be associated with infantile esotropia and associated vertical deviation. So the horizontal nystagmus is done. If we had a periodic alternating nystagmus, the Bruns nystagmus, the ataxic nystagmus, and the latent nystagmus, we had four types of horizontal nystagmus. Now coming to the third clinical category that comprises of complex and gaze-evoked nystagmus. The first one is seesaw nystagmus. It is not gaze-evoked, but it is complex. What happens here is that it is a pendular nystagmus, that is equal velocity in both directions, and one eye elevates and intorts while the other eye depresses and extorts. Now this occurs simultaneously, so this occurs like a seesaw movement. That's called seesaw nystagmus. It can occur due to paracellular tumors, syringobulbia, and brainstem stroke. Now, also you have to check for an bitemporal hemianopia in case of seesaw nystagmus. Now, coming to gaze-evoked nystagmus. Gaze-evoked nystagmus has actually these nystagmus occurs in five categories due to disorders of gaze holding. The first one is gaze-evoked nystagmus. I told you a physiological end point nystagmus. Gaze-evoked nystagmus is similar but different because it occurs at smaller angles of gazes, like at less than 45 degrees, and there's a conjugate horizontal jerk nystagmus, which appears only in the direction of gaze. No nystagmus in the primary or central position. Thus, we called it gaze-evoked nystagmus. Like person sees to the right, there's a nystagmus in the right direction. A person sees in the left, there's a horizontal jerk nystagmus in the left direction, and it occurs at even less than 45 degrees. It can occur due to any neurological lesion in brainstem in the posterior fossa, or it can occur due to alcohol, anticonvulsants, or barbiturates. Coming to the second category, now we have done ataxic nystagmus, which I told you is because of INO, and it is seen in the abducting eye. Third category is convergence retraction syndrome. This is a jerk nystagmus due to co-contraction of extraocular muscle, often the medial rectus. Now, if a person is uh, trying to like, if we keep an OK and drum, and it is rotating downwards, the upward refixation saccade, by seeing a OK and drum which is moving downwards, there will be a defoveating downward movement and a refoveating saccadic upward movement. So the upward refixation saccade will bring the two eyes in convergence. Thus, the name convergence retraction syndrome. The eyes will converge and then the globe will retract into the orbit. That is, it will go behind. So uh, here the clue to localization is that it is a component of perinode dorsal midbrain syndrome, and it is also classically associated with pinealoma. It can occur with other neoplasms, stroke, trauma, and also multiple sclerosis. Coming to a category, Bruce nystagmus is already discussed in horizontal nystagmus. Uh, Here, discussing it again, it is a component of, it can occur with CB angle tumors. So, when we gaze towards the lesion, like if there's a lesion in the left side of the brain, and the eyes are going in the left direction only, then there will be a low frequency, large amplitude gaze evoked nystagmus, and the other component will be away from the lesion, like the lesion was in the left and the person is trying to see in the right, then there will be a high frequency, small amplitude vestibular nystagmus. Uh, See this, as I told you how to document the nystagmus. These are some easy ways to recognize it. The last type of gaze-evoked nystagmus is the centripetal and rebound nystagmus. So, if there's a sustained eccentric gaze, like a person is trying to look towards the left, then nystagmus is induced. First, there occurs a centripetal nystagmus. It is something like a attempt by brainstem or cerebellar mechanisms to correct for ocular drift. So, after a sustained period, nystagmus decreases in amplitude, and then there's occurs rebound nystagmus. That is, the gaze was in the left direction, and nystagmus starts to occur in the right direction. It can occur in cerebellar diseases, lateral medullary infarction, and tumors confined to the flocculus. Thank you so much. I hope this was useful to understand the basic classification and clinical features, to understand the etiology and localization of brainstem lesions in nystagmus. Thank you.